everyone. Thanks for joining us for our first TIF Talk of 2023. We're so glad to have you with us this evening. My name is Wendy Profit. I am a market development manager with Endogastric Solutions, along with our marketing guru, Amber Berman. Thanks for being with us, Amber. Want to go ahead and let you know what an honor it is to have our special guest with us this evening. General Surgeon Dr. Chris Cottrell is a member of the team at Advanced Surgical of North Texas, as one of the only surgeons in the area to perform transoral incisionless fundoplication, the TIF procedure, for acid reflux. Dr. Cottrell is pleased to bring his advanced skills and experience to patients living in and around the McKinney, Texas area. After growing up in Houston and San Antonio, Dr. Cottrell received his undergraduate and medical degrees from Texas Tech University in Lubbock. He graduated from medical school near the top of his class and went on to complete his general surgery residency at St. Joseph Hospital in Denver, Colorado, where he was named Outstanding Resident of the Year. Dr. Cottrell's medical interests include reflux surgery and minimally invasive laparoscopic and robotic surgery, including the use of the Da Vinci surgical system. When he isn't working, Dr. Cottrell enjoys spending time with his family, cooking, and anything with a microchip. We'll get to that shortly. Looking forward to it. Dr. Cottrell, thanks for being with us.
Yeah, thanks for having me. It's a pleasure. I didn't realize it was the first one of 2023.
We decided to start off super hot from Texas. So, can you go? Sorry?
Yeah, well, not hot yet.
Yeah,
not hot right
now,
but
right? All right.
Texas.
Well, we would love to go ahead and get the audience involved. Please, if you have any questions, post them in the comments section. I see we already have a few, so thank you for that. We'll get to those as the discussion goes on. Let's go ahead, Dr. Cottrell, and start with telling folks a little bit about what GERD is.
What is GERD? Yeah, so you see this sort of a lot when people are talking about it. I have reflux or I have GERD, and people don't always understand what that is. And then people then kind of confuse that with, well, but I have heartburn. Is that the same thing? And I mean, the answer is they're all very, very related. I always think of heartburn as being the symptom that most people describe when they are suffering from GERD. GERD just being gastroesophageal reflux disease. So heartburn is just that burning sensation most patients feel kind of somewhere in here, and that is, the symptom. But the disease is gastroesophageal reflux disease, meaning anything in the stomach that's coming up into the esophagus. So refluxing, coming backwards up into the esophagus. And since it's acid, it tends to burn. So that's the primary symptom. That's the most common symptom that patients experience. There's a ton of other sort of secondary or atypical symptoms that occur, and we see those a lot when patients are being treated medically, where the acid is now gone, but they still have other symptoms, things like cough, sore throat, just kind of feeling like things don't go down properly, or actually we can still feel it coming up in the back of their throat. It's kind of the big picture of what
so can you talk a little bit about those symptoms, both just the typical, obviously chest pain, etc., and the atypical? I know we're going to roll into spring and tends to bring more patients in who have asthmatic symptoms, who have been referred over by other docs. Can you talk a little bit about that?
Yeah, sure. A lot of the patients I've been seeing recently are actually being referred more from the ENT perspective. So, patients at home and they just have this chronic cough and they're kind of otherwise healthy, and this cough, it just won't go away. And when you really look at it, the top three causes for cough are undiagnosed reflux, asthma, and postnasal drip. So, if someone has asthma and postnasal drip, those of course need to be evaluated, and that's where they kind of end up in ENT. But when that doesn't really seem to be the case, a lot of the ENT docs will send them over to me, and then we evaluate them for reflux. And so, maybe they had heartburn at some point, but for whatever reason they're not experiencing heartburn, then they'll have this cough, and the cough just won't get better. And you start talking to them, it's like, wow, it happens after I eat, particularly after I eat something that's kind of a trigger, like a tomato-based product or acid, lemonade, things like that. And so, yeah, we generate a lot of sort of patients that way, or generate a lot of patients. I mean, a lot of patients come to see me based on the fact that they have this chronic cough, and they didn't even know they've had reflux. I've diagnosed many patients with reflux, and they kind of didn't really like what I had to say initially. I was like, well, I mean, it could be reflux. Let's check it out. And then I come back with the data, and they're like, I had no idea my reflux was that bad. And then, as long as it's actually associated with reflux, then, those coughs and other symptoms tend to get better.
I continue to marvel at people who say that they experience symptoms that are so extensive that oftentimes they can't even, they'll regurgitate water that they drink. Regurgitation is not just that acid, but it can be just all sorts of things. Do you find that happens quite a bit?
Yeah, I mean, typically those type of patients, it tends to be a little bit more positional. So I remember a young woman I treated years ago. She couldn't garden, right? So she would just bend over to try and dig or plant something. It just all came up, right? And then another one was a kindergarten teacher. And as she would bend down to be with her students, I mean, like, she couldn't do it after lunch. She had to be very careful what she ate for lunch because she didn't want to, well, essentially throw up on the kids. Kids don't like that. Parents don't like it either, I don't think. But yeah, it was really socially upsetting for her. The gardening thing, I mean, if you throw up in your yard, maybe not as bad, but, literally throwing up at work as part of your job, not ideal. And so when we got her treated, it changed her life.
So can you talk a little bit about how your patients, tell you that they try to manage their symptoms and what your recommendations are for management of GERD?
Sure. So I think the first step that patients tend to do is it's almost done subconsciously, right? So you'll have patients that they stop eating Italian food, right? Italian food tends to be tomato-based. Tomato is, in general, a pretty strong trigger for acid reflux. So they just kind of start shying away from spicy foods, tomato foods, chocolates even. And so those things that tend to make it worse, they just kind of slowly shy away from. And so they just sort of start crossing those things off their list in their diet. They don't even realize they're doing it, right? Like, just kind of in a social setting. Do you want Italian food? Nah, I never feel great after I eat Italian. So then they get something else, right? Or same thing with spicy foods. So that's kind of just a natural sort of subconscious thing. And then as patients, get more and more symptoms, and even when just dietary modification, so that's what I'm talking about, the subconscious thing, but conscious dietary modification is a good first step too. Then people start taking, things like antacids and stuff over the counter. They'll sometimes see their primary care doc and they'll get placed on a proton pump inhibitor. And these are all things that can manage the acid. But the thing that I stress a lot, and I want to be very, very careful of, these are home things that people do or even seeing their primary care doc. But if you have not been evaluated with an endoscopy, I think it's extremely important to do so, at least initially, just to make sure that there's not damage that's being done. Gastroesophageal reflux disease and heartburn does put you on a risk factor stratification that is something that could develop into cancer. Fortunately, those rates aren't super, super high, but if you've had reflux for a number of years and it's been not well treated or not evaluated, you got to at least get evaluated just to make sure you don't have severe esophagitis or a precancerous condition. So for those patients that have significant reflux and they have not been evaluated, that's one of the things I stress a lot is please get scoped, right? Even if you don't want surgery, great. That's totally fine, but at least get evaluated to make sure that you don't have something that can be more serious down the road. And then we can talk about what your options are, whether it be dietary modification, medication, surgery, minimum invasive things like the TIF procedure where it's endoscopy based. And so there are things that can be done, but I think more important than anything is get evaluated, because wouldn't we all feel stupid if 10 years down the road we're treating esophageal cancer?
We often talk and put in our social media, that some of our tags are always related to just getting scoped, take a look, see what's really going on, to your point. So don't want to treat something you don't have, right?
Right. Yeah, and I have that conversation all the time. It's like, but I'm doing great. Why do I need anything? No problem. I'm glad you're doing great. Let's just take a look. And then we come back and like, yeah, you have severe reflux, whatever, but good news, you don't have ascites, you don't have any changes. You're 70 years old and you're doing great. I'm right there with you. I don't necessarily recommend surgery for you, but you've gotten evaluated. Now you at least know and you can keep living your life the way you want to. Now, that conversation's a lot different when you're 20. Do we want to stay on those medications for the next 50, 60, 70, 80, 90 years? And so, that's a whole different conversation. And it just, my job is to give them the options.
So we talked a little bit about unmanaged GERD, what it can lead to. You touched on esophageal cancer. You touched a little bit on Barrett's. And can you talk just really quickly about, that first indication, that something might be up as far as symptoms go, and say a patient is found to have esophagitis? I think a lot of times we skip over what that really looks like. What does esophagitis do to the lining of the esophagus? What does that look like in a typical patient?
Yeah, God, I wish I had a picture I could just show you, but basically, as we look down the bottom part of the esophagus, you see sort of a redness and these streaks that kind of develop of just inflammation. It's literally a kind of a burn, if you will, of the interior of the esophagus. And so when you have chronic acid just continually bathing that area, the esophagus is built to handle that to a certain degree, but not when it's just long-standing, nonstop reflux. So in those patients, after a certain number of years, you'll start to see some inflammation, right? And so it's just kind of there's different gradings. There's kind of a Los Angeles classification, A, B, C, and D. And, A is kind of one streak, and then 2 streaks is kind of B, and then C is where a couple of those streaks kind of cross some folds, and it just more extensive all the way around is kind of as it goes higher and higher. And so, yeah, it just looks like a burn, an irritation of the bottom part of the esophagus.
All right. So patient comes in, they have GERD symptoms. You visit with them and decide it's time to go ahead and take a look. Can you talk a little bit about the testing that's involved with GERD diagnosis?
Sure. I think one of the things that patients get super frustrated with with doctors, there you go, with doctors is that, this, and then you got to go see another doctor for this, and then they talk to you, and then you got to come back over here and do this. And you get patient fatigue with, go on for too long. Like when you go to the dentist, that's a root canal, and then you got to come back, they do the first thing, and then you got to come back and have it packed, and then they come back and prepare the crown, and then, it's just like this whole set of things with 4, 5, 6 appointments. It's like, who has time for all that, right? So I've always tried to be efficient and straightforward and get, as much information I can very quickly. And so what I really try to do is, I do my own endoscopy. And so we set them up for an endoscopy, right? And we're just evaluating for esophagitis, for Barrett's, which is the precancerous condition. You mentioned Barrett's, I mentioned precancerous condition, but I didn't connect those. So we're looking for Barrett's esophagitis, which is when esophagitis progresses to a more serious condition. And then, so once we've sort of looked at all that, then I do a Bravo pH probe. So we place a little capsule in the kind of bottom part of the esophagus, and over a 4-day period, that measures the pH on a minute-by-minute basis so that we can, really put a number, an objective number on how bad the acid reflux is. And so that works great. And then while we're there, we can measure some of the contractility of the esophagus, which helps us decide what the best approach is down the road. Kind of for people that are considering surgery, it's very good data to have, so we know how to prepare them for the after part. If they decide on not having surgery, you don't necessarily need that piece, but again, getting it beforehand, we don't have to do anything else afterwards. So if the patient goes ahead and decides, yeah, you know what, this sounds great, I don't want to take medication for the rest of my life. I have breakthrough symptoms on my medication, and so even though the medications are doing okay, I feel like I could do better. Then, so then we talk about surgery, and we've done everything we need to do. Boom, we're off and ready to go. And so we're minimizing both the expense, but the time that a patient has to spend getting worked
Excellent.
up
And for those
condition.
of you that are new this evening and just starting your journey to research and find out a bit more about your conditions, diagnostic testing, I've had some folks say, now, is that while I'm awake?
No. Yeah, the good news is, so there is some testing that gets done awake. That's not super fun because things go down your nose and it's pretty gag inducing and just not, I've had a lot of patients that talk to me about it when they've had it done and it's just awful. This is done asleep, right? This is an endoscopy. You get sedated. There's an anesthesiologist present. They're monitoring you. You are asleep. Now you're breathing on your own, so you're not full on breathing tube asleep. But as far as you're concerned, you're asleep, right? There's no recollection. There's no pain. There's no discomfort. The pill itself, I've had a couple patients, not many, that sometimes when they swallow food, they can feel just a little bit of a hang up, kind of like when you get something cold down there. But for the most part, it's extremely well tolerated. The pill then falls off on its own, and you don't have to bring it back after it passes. And then, and that's it. And then you just bring the little box back to the hospital where we did it, and then we analyze the data and go over it in clinic.
So we've moved from testing on to a diagnosis, right? We're going to jump into what options are available to treat GERD in just a second. What I would love to do first is hand the reins over to Amber, who has had several questions come in, and take it away, Amber.
Thank you, Wendy, and thank you, Dr. Cottrell, for spending time with us. So we have a few questions here. The first one from Marie. What kind of help is there for GERD besides medication? I've been taking omeprazole every day for a couple of years and have also been prescribed famotidine. I hope I didn't butcher that. Famotidine, thank you.
Famotidine. Yeah. So, the one thing is, again, if you have not been worked up, definitely get worked up, right? So definitely, at the minimum, get a scope, right? So just to make sure there's not any serious conditions going on. Now, that being said, let's say we get down there and we've identified the reflux, we put a number on it, and then the next step is whether you want to continue taking the medication or whether you want to consider surgery, right? And surgical options is kind of the next step after medication, right? So we can do medication, and then sometimes we can go to twice medication, we can maximize medication, dietary modification. These are all medical treatments. So we can maximize that as best we can. Then the patient has to decide, am I doing well enough that I'm happy, or do I want to take these medications? And if the answer is no, then the next step would be a surgical correction, right? So when we talk about surgical correction, we're doing a couple things. Number one, we're restoring the natural anatomy. So when patients have reflux, usually there's a breakdown of the relationship between the esophagus and the stomach and where it sits above or below the diaphragm. So when it's below the diaphragm, the intra-abdominal pressure, so the pressure inside the abdomen will press on, I always say squish in the office, squish the esophagus and creates a valve, right? But it's reliant on that relationship of the esophagus being below the diaphragm. It's above the diaphragm, right? And so if the stomach has come up a hiatal hernia, that has to be repaired, right? So we repair that surgically. That's literally a robotic surgery, something I'm passionate about, minimally invasive, small incision. We can pull the stomach into the correct location. I say that, it's a little more complicated than that, but basically we can get the stomach into the correct location, restoring that esophagus below the diaphragm. Then we repair the muscle so that it doesn't come back, right? So that's part one, repairing any hiatal hernia that exists. The second part revolves around creating some sort of anti-reflux barrier, so some sort of valve, right? So traditionally, that's literally taking the stomach and wrapping it around the esophagus. It's a good operation. It's been around for a number of years. It does work. It's a little overkill sometimes. Patients get some bloating and some symptoms that make it hard to burp, hard to vomit, and can be pretty uncomfortable for some patients. And then as the patients age, we start to see that dysphagia or problem swallowing kind of creep up as that valve is too tight. The endoscopic approach, or the TIF, transoral, incisionless, fundoplication, that means wrapping of the stomach, is a great option because it offers the same benefit, the same valve creation, but without having to actually physically wrap it, and we just don't see the side effect profile. So it's a great option. It's a great valve that gets created. And as it's been studied, we're seeing that it's at least as good, if not better, than what that traditional wrap was. And it works great. And on the off chance that it does fail after a number of years, it's actually easily repeatable, whereas the other options really aren't. That was a long answer to a very quick question, but
no,
surgical.
That was great.
The quick answer is the surgical option.
You summarized them great, and it sounds like patients do have quite a few options if they decide the PPIs are no longer working or they just don't want to take them anymore.
Well, and every patient's different. When we do this workup, this approach may be more appropriate for you based on, the level of esophagitis you do or don't have, how big of a hernia you have. Small hernias, we can actually do completely endoscopically without any incisions at all. And that's the coolest thing ever, right? So, you just wake up and, my reflux is gone and it looks like no one touched me.
So there was one other question. There's a few here and we'll get to them, but because this one is specific to something you just said, I'd like to address it. At what point do you think surgery becomes necessary? And are there other options that should be tried before deciding on surgery?
So I think we've covered the other options, right? I mean, you want to maximally, modify your diet, medications, losing weight. I guess I didn't touch on that. Losing weight can definitely help because a lot of this has to do with the intra-abdominal pressure. So the more pressure we have, the more weight that we carry, the more pressure there is. And so you can see someone with early reflux after they've gained some weight. We saw a lot of that with the pandemic. As the reflux comes on, if they lose some weight, that can really help quite a bit. And that can be a pretty good treatment for their reflux. When it comes to when patients decide or when it's right for them, it's kind of a patient decision for the most part. How comfortable are you on your medications based on where your symptoms are now? If you're doing great on medications and you don't have esophagitis, you don't have precancerous changes, if you're already feeling wonderful and we don't have anything that's pointing to the medication not doing you good, I can't make you happy, right? It's just, do you want to take the medication? I have people that don't want to take medications, whether it be from a holistic point of view or they're concerned about side effects. Totally understand that. So they're doing well on medications, but they don't want to take them. They don't want to have to take them. They're young. And so it's when you don't want to take your medications or you're worried about some of the side effects. The other thing that I see is patients that are on medication, but they're having breakthrough symptoms, right? So maybe their heartburn's controlled, but they're having that cough. They're having the regurgitation, the choking stuff that still happens because they're still refluxing. It's just no longer acid. So if you're breaking through your medications, you don't want to take medications, those are the patients I typically see that want to go on.
Yeah, that makes sense. So you did speak a little bit about the TIF procedure before, and we have a question from Jose about the safety of the TIF procedure. Can you talk a little bit about that and what you've seen in your patients?
Sure. Like anything in medicine, you have to be careful, right? There are a couple things that make the TIF procedure not a great idea, particularly really severe esophagitis. But unless we see that, the TIF procedure is extremely safe. The overall perforation rate or complication rate is extremely low. Patients come in, we do surgery. I think there's some doctors that are sending the patients home the same day now. I'm a little old-fashioned. I kind of like to watch them overnight just to make sure everything looks great, but the vast majority of patients go home the next day. They go home on a liquid diet, and they're back to a normal diet somewhere around 4 to 6 weeks, depending on the patient and exactly what we did. But overall, it's extremely safe. It's not something that is got a high complication rate
That's
anyway.
Great. And as you said before, fewer side effects, right? So it's yeah, excellent.
Oh, way less. Yeah, way less. I mean, people can burp, people can vomit with ease, and they have less issues with problems swallowing.
Well, we do have one more question from Chuck. What is the recovery process like after TIF?
Sure. So I think I just mentioned that they stay overnight, right? So we just check on them the next morning, make sure everything's going well. We're looking for fever and other signs of complication or infection or something like that. It's extremely rare, but basically most patients go home the very next day. Every now and then I have a patient who will stay one extra day, just whether it's their pain's not controlled or something, nausea maybe. But yeah, the vast majority go home the first day. And when you go home on liquid diet, right? Liquid diet, anything that can go through a straw. I typically keep that on for about a week or two. And then you're back into the office and we're managing that going through soft and slippery foods and soft and moist and then on to regular foods somewhere 4 to 6 weeks. And so the biggest thing that annoys people when they come back and see me is that they're real sick of yogurt and pudding as soft things. And maybe they're a little bit hungry because they want a steak or whatever. And some bloating, as well as the no heavy lifting, right? So for people that work out, people that lift weights, no heavy lifting more than 20 pounds for 6 weeks. At least that's my rule. Doing that puts strain on what we just repaired, making it more likely to recur or have problems. So we restrict people for 6 weeks. Now, after 6 weeks, you can do whatever you like. But until then, yeah, people get a little frustrated with inactivity, especially when they otherwise feel good, because even though we have that longer period of diet and the weightlifting and all that, most people feel pretty darn good at a couple days to a week, and the pain's not very much, and they're back to their normal activities and feel good, and then just kind of like, I want to do something, but I can't, So that's, I think, the biggest frustration is not being able to do a lot of, exercise when they're feeling pretty good.
Yeah, that makes sense. And it's pretty comparable, right, to what the other, the recovery process, I should say, is comparable to what other surgical options are, with what you see.
Yeah, the TIF alone, if you just do the endoscopic, it's quicker. There's no question about it, right? They typically, I try and tell, I always err on the side of, low expectations. So I kind of tell people in the office, 4 to, sometimes even 8 weeks that it takes to get you back to regular food. But with TIF patients, man, it can be 3 or 4 weeks. I mean, it can be really, really quick because things settle down much quicker. With a more aggressive approach, whether it be the hernia repair, robotic, more of the traditional Nissen type things, then yeah, it's a little bit slower. So they're comparable. It's just really about the speed, right? TIF alone tends to be faster. Then TIF plus hiatal hernia is kind of in that middle ground, and then the traditional surgery is kind of the slowest. But,
got it. Thank you so much, Dr. Cottrell.
And, I'm going to ask
Sure.
too, since we're talking about combined procedure, TIF plus a hiatal hernia repair first, right? And then TIF is done afterward if that's what's warranted for the patient.
Yes.
We do often have folks who say,
yes. Same day though. I have that question. I have that question all the time. Same day, same surgery. So I think some people kind of think like if you separate them, you're just doing that for the, for insurance purposes or money purposes. No, it's done at the same time, right? So we do the hernia repair, and then once we finish with that, then we literally put the scope down and do the TIF at that time. So it's not 2 anesthesias, it's not 2 procedures,
and
not 2 days.
Do you have, an idea of how many folks, that opt for one of these procedures, how many of them actually have a hiatal hernia if they've been diagnosed with GERD versus not?
The vast majority. Yeah, I mean, really, when you think about when you look at the actual mechanism for reflux prevention, when you look at the physiology, the esophagus and stomach, and how it all works, yeah, there's other reasons you can have reflux without having a hiatal hernia. So anything that would increase the internal pressure, pregnancy being a very good example of that. We don't treat those patients with surgery, right? We let the pregnancy progress and deliver, and then if their reflux continues, then we can evaluate them. Other things that delay the gastric emptying, increases the intrastomach pressure, and that can promote reflux. And so that's kind of a different scenario. But for the average patient without a whole lot of going on that just has reflux, yeah, there's usually going to be some amount of hiatal hernia. For me, it's just a matter of how big it is, right? Smaller hernias we can deal with just the endoscopic TIF approach versus larger ones we really need to address more with an actual robotic.
Thank you. So when we talk about life post-TIF and what that looks like for folks, you touched on that a little bit. I would love to just kind of give you a rapid fire on activities that are yay or nay after you've had the procedure done within those first 8 to 12 weeks.
Okay, 6 weeks. Well, yeah, 6 weeks.
Okay.
Weightlifting stuff and restrictions for me is 6 weeks.
And then how about your golfers?
So golfers, putting, yes.
Okay.
Swinging, no.
How about your
Playing
runners?
clubs, no. Yeah, runners as soon as you feel like it. Typically, and because back when I first started doing this, I had a nice list of a bunch of things, right? These are the foods you can eat. These are the activities you can do. And what I've learned as I've gotten hopefully wiser is lists generate questions, right? People are naturally, they want to look for loopholes, or this list isn't exactly me, so I need to ask that question. It actually generated more questions than it answered. So when, my first list, I was out there, and then I have a patient come back, what is a soft fish? I don't know, as long as it's soft. I mean, like they wanted exact, examples. Does that include tilapia? What about tuna? I'm like, oh my God, I have no idea. So what we talk about is, the consistencies, and so that hopefully you can apply those with a little bit of common sense, right? So when we talk about exercises that are done, anything where you have to strain against your core, so like anything where you're like that, no, right? So I do give examples just because that helps people understand things. People that work out, they know this, right? That's easy. It's the people that don't work out that you have to kind of walk them through this a little bit. But things that are relatively low impact can still be no. Yoga is almost always a no because you're not doing nothing but straining against your core. Obviously, weightlifting is a no. Running is usually okay. If you're going to do hardcore steps and stairs and plyometric type stuff where you're jumping over hurdles no, that's a no. But standard jogging or running, great. Stairmaster, usually okay as long as it's not hardcore. Treadmill and elliptical, great. It depends, right? If you're just going to pedal the bike, great. If you're getting up and doing spin type stuff like Peloton, up, down, and high resistance, no. So if you're straining, no. If you don't have to strain to do it, then it's probably
I love that
okay.
you talk about, the importance of, just making sure you're not engaging that core a lot, because I don't know that that's something that we've really touched on. We talk about listening to your body all the time, right? And if it seems like it's a good idea, it probably is. If it seems like, I don't know if it is, it's probably not, right?
Well, let me expand on that just a little bit, because really when you anatomically, physiologically, it actually makes sense, because when you're straining, what you're doing is you're literally tightening the muscles and you're increasing the abdominal pressure, which is putting tension on what I've just repaired. So you wouldn't do that, right? Like if you pour concrete, you're going to let it set before you walk on it. So it's the same idea. So that's what we're trying to prevent. So it's not I'm just trying to be mean. I'm not trying to keep you down. Nothing like that. It's just that straining until what I've done heals is just not a good idea.
And while we're talking about healing, a lot of folks, we see a good amount of discussion in different support groups online. Social media is a great place for folks to gather and just exchange their thoughts, their ideas, and talk about what they've experienced, no matter where they are in their journey. And what we see is a lot of folks express concerns about whether or not they feel like they're healing properly after any type of anti-reflux procedure, or even after a scope, and they say, what is going on? I'm having a bit of a challenge swallowing where I wasn't before. And it's, most times it's that healing process. Can you talk a little bit about what happens during that healing process to help people understand a little bit?
Sure. Yeah. So the way I describe it to my patients is that, right after I'm done, it's ideally perfect, right? It's exactly the right size. It's exactly the right wrap, and everything is perfect. Unfortunately, the human body is not a quilt or a machine. So when we do something to it, it swells, right? And so when things heal, they swell. So if you cut your arm, a day later, you can see the line and there's a little bit of swelling around it. When we take the esophagus, right, the esophagus being a circle, give or take, and then we got to use geometry. So we got to go back to like 9th or 10th grade. But the cross-sectional area of a circle is pi r squared, right? So if the radius decreases by, a little tiny bit, the cross-sectional area decreases by a factor of a square. So just a little bit of cross-sectional area decrease really makes it a little bit difficult for stuff to get down. And that's just from the swelling. That's human body swelling. So that's why we go home on liquids, right? So I get patients all the time. They call me, they're like, oh my God, I forgot I had mashed potatoes. That's not a liquid. Oh my God, I'm going to die. How do you feel? Fine. You're fine, right? The diet, messing up, quote unquote, isn't going to hurt the repair. It's just going to hurt you. It's uncomfortable because it won't go down properly, right? So not too long ago, we actually had to fish, sausage out of someone who had forgotten and down to some soup, and there was a piece of sausage in there, and so it got stuck, and so we had to take it out. And so he was very uncomfortable until we got it out. But he did fine. So, that's kind of the worst case if you don't follow the diet. It's just uncomfortable if you don't. So, the diet is really more about your comfort and just making sure that, you can get nutrition and that things will go down and you don't get stuck and end up in the endoscopy suite trying to get, a piece of sausage or hot dog removed. So, yeah, but basically the reason that happens is just because of swelling. And then over a couple of weeks, that swelling relaxes and then you can eat normally. And so that's kind of the big reason for the change in diet. Every now and then I have a patient that for whatever reason, they swell a little bit more. And so that's one of the reasons we watch overnight, because like once or twice a year, we see where a patient just for whatever reason, the swelling is just a little bit more and swallowing is just a little bit difficult that first day or so. And sometimes we'll actually send patients home on like a steroid pack just to, kind of make sure that things get better. And they do. I mean, it's pretty rare that we have to like dilate or do any kind of adjustment afterwards. Usually just a matter of waiting for the body to heal.
Thank you very much. So we do get questions sometimes about the TIF procedure, and if, just as far as the durability of the procedure goes, if down the road, years later, if any type of enhancement has to be done, if something needs to be tightened up, what are your thoughts on that?
Sure. I have two thoughts, right? So the first thought is that we are seeing both empirically in terms of study data that's coming out that it is a very durable procedure, right? And I'll touch on that in a second. And the second part is, we also see that in practice, right? I'm not seeing patients coming back 2, 3, 4, even years later saying, it's not doing well. Not in mass quantities anyway. So the original data that was done, really looked like that we saw people about 80%, give or take, got off of their medications, right? So they got off the daily medications with the initial, TIF studies that were done. And so, that's 80% success rate. That's actually very good when it comes to scientific data. And that's with just TIF alone. That doesn't include hiatal hernia. So then they kept those patients in the same series and they kept following them out long term. And at 6 months, that number really hadn't changed much. So now we're out to like 5 and 6, 7 years later. And basically with just a few drop points, we're still seeing 75, percent or so that are still having good control of the reflux. So we're seeing that it is a durable procedure. Yeah, I mean, unfortunately, there's 340 million people in the United States. You take one thing and apply it to everyone. Yeah, there's going to be an occasional failure. There's going to be an occasional problem that has to be readjusted. But for the most part, it is a durable thing, and we expect it to be something that lasts for a very, very long time, if not lifelong. Now, the second part of all of that is if it needs to be, it's an easy thing to do, right? A repeat TIF procedure is really not any more difficult than first TIF procedure, whereas a repeat Nissen is something that is not to be taken lightly, right? Repeat hiatal hernia repairs, which is something that I do, is something that we have to have a pretty good conversation with the patient to understand that there's a lot higher risk of esophageal injury, injury to the stomach, inability to even do the procedure because of scar tissue. The aorta is all right there. So we have to be very, very careful when we're doing the repeat Nissen or hiatal hernia repair. Whereas a repeat TIF is virtually the same procedure with the same risk. And so we don't really have that, same risk factor going in. So if you're one of those smaller percentage of patients that did have to be repeated down the road, relatively easy to do. So no, it doesn't happen very often, but it does need to be repeated. But if it does, it's easy to do. Hope that makes
Wonderful.
sense.
Thank you very much. So what are the things that your patients enjoy that they weren't able to do before their TIF procedure?
Orange juice. That's the big one. It's not that, I don't even like orange juice that much, but yeah, for people that, enjoy orange juice, that's something that's a no-go with reflux. Now, you talk to anyone that has reflux and they just don't drink orange juice. So orange juice is a big thing. Italian food, obviously. People that enjoy an occasional alcoholic beverage, a lot of times reflux will make that worse. So that, and particularly red wine. Red wine is kind of one of those triggers as well. So people that can return to some of those activities that they enjoy quite a bit more is a big deal. Food is life, right? Food is family. Food is celebration. And people have to limit themselves from that. They don't do well. Right? It's when you are around all your friends and family doing something and you cannot because you're going to feel not great, then yeah, when you can return to that, it's pretty empowering.
Excellent. Thank you. Amber, I hear we have a question.
We do have one additional question from Jeanette. So Jeanette says, my vocal cords are swollen and engorged from GERD inflammation. Will the TIF procedure bring it down and prevent my voice from cracking afterwards?
Sure. That's one of those secondary symptoms that we don't sometimes see. So, and I've treated patients, but the only symptom they seem to have is a hoarse or kind of coarse voice. And it's something that slowly develops, right? You know, we don't pay attention to our voice that much. Particularly when it changes slowly over time. So I'll meet someone that's kind of more my age in their 50s, and you know they kind of have like a hoarse, scratchy voice, and I'm like, "Has your voice always been like that?" And they're like, "Huh, no, I don't guess so." And then their husband's going like, "No, never mind," you know. And so it's something that happens very, very slowly, right? And so over time, that acid comes up in the back of your throat, literally, you know, engorges and inflames and irritates those vocal cords, and causes your voice to really be quite different. And fatigable, right? So you can have a voice that's sort of okay in the morning, then as you go on during the day, it gets hoarser and hoarser, or tireder and tireder, weaker and weaker, all those things. In general, the TIF procedure is definitely going to reverse any acute changes, right? So it will stop the acid from coming up there, and so any continued damage to your vocal cords should get better. What we typically see is we're going to see improvement over a period of time. Right. So if it's a chronic, long-standing problem, we do not expect improvement right away. Right. It takes a while for those vocal cords to heal. It takes a while for them to stop being engorged, inflamed, and you know, we expect some healing in the first couple of months. Now, the other problem is that if it's been going on for a really long time, they can be kind of scarred. So it may not go back to normal. So if your voice is fairly hoarse and scratchy, and it's been going on for quite a long time, and we do something to correct that, it might get better, but I would not expect it to get back to like when you were 20. So yeah, we should see some improvement. It's just how much scarring do you have and how much improvement do we see? So we should see some, but maybe not all the way to, you know.
Yeah, that makes sense. It's interesting. I'm sure most patients don't realize that a change in your voice, especially if you're not experiencing reflux symptoms, heartburn, could be caused by GERD. That's great. Thank you.
Absolutely. Yeah, and I would say, and I think my ENT friends would agree, if you have voice changes that happen over a relatively quick point in time, boy, that needs to be evaluated, right? Because yeah, we're talking about reflux today, but there are so many other more severe conditions that need to be evaluated if you develop a hoarseness that's a new onset, particularly if you're a smoker or you know any kind of smoke with tobacco or something like that. So yeah, please get voice changes evaluated very quickly, right? That's not something to ignore. Now, if you've had a cold, your voice changes for a couple of days and it returns to normal, that's not the same thing. I'm talking where you are normal and all of a sudden your voice starts to change and does not get better. Now, I would not sit on that for very long
That's
at all.
great. Thank you so much, Dr. Cottrell.
Sure.
Well, all right. I would love to wrap up tonight by letting everybody know, if you don't already, it is National Cancer Prevention Month. And what better forum, you know, for us to go ahead and talk about building awareness there.
Twice. Throat cancer and esophageal cancer we talked about. So yeah.
Indeed, indeed. And oftentimes, correct me if I'm wrong, you're not symptomatic, you know, when that starts to develop. So again, the importance of, if you do have any type of GERD symptoms, making sure that you're consulting with your physician and an expert who can really see what's going on is to everyone's benefit.
Absolutely.
Very good.
Absolutely.
Well,
yeah, the only thing I'd love to say, if you don't mind, is just, you know, there's, you know, tons of stuff on social media, and I've got a fairly active social media presence. So whether it be Instagram or even TikTok, at Chris Cottrell, MD, there's a lot of the same information sort of broken up in little snippets over time. We've been doing it for quite a while, so there's a lot to look at. If you have any other questions, we're certainly available there.
Excellent. Thank you. Yeah, social media has been just such a wonderful resource for folks to really, I think, add a lot to their experience. We also have a patient education app that Endogastric Solutions and the GERD Help channel offer. And if you would like more information on getting that app, you can go to your app store and type in GERD Help, all one word, download it. It's free to use and provide some really helpful education in that area as well. So what I would love to do is close up this evening, Dr. Cottrell, by just having you talk about what parting thoughts you might have for your viewers tonight. The floor is yours.
Yeah, I think one of the things I'm going to say it again is, if you're in doubt, if you don't know, get evaluated, right? So in the social media sphere, we get these questions all the time. I'm dealing with this and no one will help me or whatever. And so I think finding a doctor that specializes in reflux is a very important thing, right? We have televisits available. I see patients from actually all over the country and the world, actually, as it turns out now. And so we're happy to help you as best we can. Obviously, I treat patients in Texas and in the Dallas area. The website that you mentioned, gerdhelp.com, and other things like that, at least get to see someone that specializes in reflux, because every physician has a different perspective. And so make sure that you're seeing someone that at least has an open mind to talk about other perspectives than just medications. And I think a lot of patients get super frustrated with, they have reflux, and people keep telling them to take these medications, and, they're not getting scoped, or they're not getting the help that they think they need. And even if they decide not to have surgery, at least know what the other options are. So seeing a doctor that specializes in reflux, I think, is a super important part of it. And then as part two of my final there, of the wrap up, is get evaluated, right? At least get a scope. Even if you decide not to have surgery, that's great. Just get scoped to make sure that we are not missing something more significant.
Excellent. Well, we can't thank you enough for your time tonight and sharing your expertise. It's been a wonderful, wonderful evening. I would like to let everybody know, if you are in the Texas area, you are experiencing symptoms and would like a visit with Dr. Cottrell, please look him up. We also have a physician directory on gerdhelp.com. You can simply type in your zip code and be connected with TIF experts in your area. We want to thank everybody for attending tonight. We're excited to be back with our TIF Talks for 2023, and we'll look forward to seeing you every Tuesday. Look for your local times in listings on your feed on Facebook. Thanks again, everybody. Have a terrific evening. Dr. Cottrell, it's been a pleasure. Amber, thanks for joining us, and we'll see everybody next time.
Thank you.
I'm 9+ weeks out from surgery. It's pretty surreal that I keep waiting for heartburn to happen. I keep waiting for the GERD symptoms to come back after I start, implementing foods that I can eat again. And it's not happening. I feel very happy. I feel very grateful. I feel solid in knowing that the TIF procedure worked. I've been running again. I can do push-ups. I can bend over and pick something up without acid coming up into my throat. Yeah, I'm serious. I mean, that's where it had gotten. The dry mouth and the dry throat and dry esophagus, it made it really difficult to speak. And I would get a sore throat a lot from sleep. When I would sleep, the acid would come up into my throat and I would wake up with a sore throat and a hoarse voice. Now I wake up, maybe I think about it because I'm conditioned to think that way, but the cool thing now is that if I do have that thought, which is fluttering away each day, but if I do have that thought, I quickly can scan myself and there's no heartburn, and there's no sore throat, and there's no wheezing, and there's no fear about having a cup of coffee. I just don't wake up feeling defeated and sad and down. I mean, if somebody is having severe GERD symptoms and they've exhausted all their options, even if they haven't exhausted all their options, if they have severe enough symptoms like the symptoms that I had, I would 100% suggest the TIF procedure, because it's been a complete 180 to the way I feel and for the things that I'm able to do now. So if somebody has severe GERD symptoms, chronic acid reflux, I would 100% recommend the TIF procedure.